Good evening. Assalamu alaikum, everyone. This is Farzana Wali Liza, Chairman, International Medical Information Center, IMIC. Welcome to IMIC Live. Being diagnosed with cancer is an unfortunate dilemma, and life becomes unpredictable. Proper treatment management, guidance, inspiration, self, and spiritual faith helps us to bounce back. Surgery is used to prevent, diagnose, stage, and treat cancer. Surgery can also relieve discomfort or problems related to cancer. Sometimes one surgery can take care of more than one of these goals. In other cases, different operations may be needed over time. The global impact of the COVID 19 pandemic has challenged the healthcare system worldwide to provide quality care, especially for the emergency cancer surgery. As a part of our awareness program to lead healthy life, International Medical Information Center IMIC Limited, Bangladesh, and Fairpark Hospital, Singapore jointly arranged this webinar on advanced cancer surgery achieving the impossible. Our media partner is Shasta TV, and our associated partner is Banket Bangladesh Cancer Trust. Thank you everyone for joining with us. Please share your valuable comments and queries on our Facebook page during the live session. Let's discuss with our experts from Singapore and Bangladesh to know more about surgical oncology and its advancements. Before introducing our experts, let me inform you about Fairpark Hospital. Fairpark Hospital is focused to bring value to people through solutions for holistic healthcare, hospitality, and wellness. Architecturally designed to use the landscape and surroundings of Singapore's iconic Fairpark location, which is on the top of the Fairpark Mark station. Fairpark Hospital ensures patients with modern and efficient healthcare services with the current developments in medical technology, treatments, and innovations. So let's get introduced with our today's highly esteemed speakers from Singapore and Bangladesh. First of all, let me introduce with Professor Dr. A.F.M. Anar Hussain, sir. He is the ex-professor and head of surgical oncology, National Institute of Cancer Research and Hospital, Dhaka, and senior consultant at head Department of Surgical Oncology, Ashlania Mission Cancer and General Hospital, Uttara Dhaka, Bangladesh. And as per his achievements, it's difficult for us to explain everything, but Professor Anwar Hussain had his fellow on surgical oncology from Tata Memorial Hospital, Mumbai, India, and trained in surgical oncology from Memorial Sloan Kettering Cancer Center, USA. Thank you, sir. Thank you for joining with us. Thank you for your time.
Thank you. Thank you, everybody.
So now I'd like to introduce with you Professor Melissa Teo, Surgical Oncology Clinic, Fairpark Hospital, Singapore. Thank you, doctor, for joining us. So Professor Teo has a vast experience who graduated from the National University of Singapore and completed her general surgical training in the Singapore General Hospital and National Cancer Center, Singapore. She was awarded with Sing Health Human Manpower Development Plan Award to pursue further training in complex abdominal and pelvic surgery. With a keen interest in treating and curing cancer, she completed two fellowships in surgical oncology and in colorectal surgery at the University of Toronto, Canada. And Dr. Teo remains one of the few accredited surgical oncologists in the country and region and is frequently consulted for the expertise in the management of the gastrointestinal cancers, sarcomas, melanomas, colorectal cancers, and peritoneal diseases. Uh, so Thank you, Dr. Melissa Theo, for joining with us, and we are waiting to hear from you.
Thank you very much for the kind introduction.
Thank you. So, first of all, I'd like to start with Professor Anwar Hussain sir. According to our Bangladesh perspective, we'd like to hear from you the holistic care or approaches we have here in Bangladesh and the cancer conditions here in Bangladesh. How it is spreading here? What's the condition? Please, sir.
Okay, thank you. Uh, okay. This is better. Thank you, everybody. Can you hear me?
Yes, sir.
No.
You're
Okay.
audible, sir.
Okay. Good afternoon, and most welcome to everybody. Thanks to organizer for arranging this webinar, and it's a great pleasure for me to be here in this program. And simultaneously, my heartfelt thanks to Professor Melissa, a surgical oncologist from Singapore, to join over here. Actually, there are few centers in Bangladesh where cancer management is going on, but National Institute of Cancer Research is the primary place where I was there for the last few years, and lastly I retired from this place as Professor of Surgical Oncology. And the organizer come forward with the theme to share and disseminate about the situation of cancer diseases of our country. The first and foremost important thing is the diagnosis. Diagnostic facility is very much important before doing any intervention regarding surgery or any other approach. So the precise diagnosis is very much important for cancer management. That could be FNAC or 4 by 2, whatever it might be. And as because this is for the general population mainly, that is why I'd like to say a few words about the people. They want to know about the staging of the cancer. What is my stage? So there are some investigations which is needed for the staging of the disease. Actually, people are interested to know much more from our foreign faculty. Even though I would like to say a few words more. The coming month is the October is the breast cancer awareness month. It is a worldwide program, and main theme of this program is the awareness among the people regarding the cancer, early diagnosis of the cancer, and definitive treatment at the highest level to attain. And because most of the patients in our country present in a very advanced stage of the disease, whatever it might be the cancer, breast cancer, GI cancer, melanoma, sarcoma, whatever it is. So I would like to share few scenario of the cases, um, which is important to know. My first case is a 45-year-old woman presented with a diffuse lump in her left iliac region extending up to the left lumbar region for the last 8 months. Recently, she developed pain in the same region. History of alteration of bowel habit and bleeding for rectum for the last 3 months. History of occasional fever. And she undergone colonoscopy, and colonoscopy revealed ulcerated lesion in the descending colon with marked narrowing of the lumen, and the findings suggestive of tuberculosis. And for which, and this is the presentation of the lesion in the descending colon, and it is highly suggestive of tuberculosis. But on CT scan, it was found that there is growth in the sigmoid colon, and which has infiltrated the surrounding soft tissue structures. With this presentation, we have seen that these are the lesions, and finally, MRI done, and MRI report revealed descending colon mass and pericolic fat and peritoneal partial involvement and multiple paracolic lymph node. But even then, it was not diagnosed, and she was diagnosed as a case of tuberculosis, and she had on anti-tubercular drug. So the situation is very bad. That is why we undergo laparotomy, and patient undergone operative intervention in the form of laparotomy, and there was a growth involving the sigmoid colon addend to the lateral parietal wall and part of the urinary bladder, and also the retroperitoneal structures. And after meticulous dissection, it was removed. And final report is that it is a case of adenocarcinoma. So this is a malignancy. So this is the information what I want to ventilate, that the diagnostic problem leads to there is delayed in the management. Another important case is I go very quickly. 65-year-old man having upper abdominal pain and discomfort and with vomiting for last 1 year. He had upper GI endoscopy, and all over the stomach it was found that congested and benign looping ulcer in the antrum. This is the lesion. So there is a lesion in the antral region, and the histopathology report revealed it's a poorly differentiated mucin secreting adenocarcinoma. So CT scan of the whole abdomen done, and there is a circumferential growth in the body and antrum. So it has been found that there is a lesion in the antral region along with lower part of the body. So preparation was taken. These are the CT scan finding. So CT scan finding is not consistent with the laparotomy finding. On laparotomy, it was found the whole abdomen was involved by the tumor with infiltration with the regional lymph node. But unfortunately, there is no liver, momental, and peritoneal metastasis. And total gastrectomy was done, and final report with the adenocarcinoma was same as endoscopic report revealed. So this is the final report: adenocarcinoma, poorly differentiated, and this is the post-operative X-rays. I very quickly completed my third case. A 43-year-old woman presented with huge mass in the abdomen, extending from the mid abdomen to upper abdomen for the last 2 years. But nobody can understand what has happened, and for which she undergone Apache endoscopy. There is a large mass. Endoscopy revealed only gastric enteritis, enteral gastritis, and ultrasonography shows soft tissue mass, but CT scan finding revealed there is a huge mass. And ultrasound guided if it is core biopsy is the gastrointestinal stromal tumor. So there is a long period to, to come to a conclusion what has happened with this patient. So early detection of the cancer is very much important, and this is the presentation of this patient. So there is a huge growth which has involved the umbilical up to the epigastric region. And this is the histopathology report rectoperitoneal mass with the gastrointestinal stromal tumor. Thank you.
Thank you so much, sir. These are the actually really fascinating information for our patients who is suffering from cancer or recently diagnosed with cancer. That always there is a hope, and our surgeons are doing a fabulous job with the success stories. But with this discussion, I had a question in my mind that it's a I mean, according to our social and religious norms, sometimes the women feels uncomfortable to discuss about their colorectal problem, or even they don't want to disclose their problem with the family. So when they diagnosed with the last stage, or the disease is already spreaded, so how you deal with this, and as a male doctor, how you deal with this situation, especially for the female patient. And I can see a patient who is 45 years old and a very young woman. So, sir, what's your advices for the women who is now watching you, especially for the colorectal diagnosis?
The important thing is that the actually most of the patients present very late and they are not known where to go. This is very much important. The appropriate person is needed for appropriate measures to be taken. So the scenario is that whatever might be the disease, it is whether it is breast or stomach or colon, whatever may be, that the earliest possible time with having initial presentation, if they go to the doctors, nearby doctors, at least they can send the patient to our district level hospital or nearby divisional hospital or to the specialized hospital. Where the immediate measures to be taken to, first of all, diagnosis. If diagnosis is made, then the appropriate measure will be taken very quickly. And the important thing is that cancer has no answer. This is not actually right now is the appropriate terminology. It is obsolete, and that is why there is the execution of screening program, both for the breast cancer screening, also for the colon and stomach cancer. Even Japanese people go for stomach cancer screening. So screening is the one of the important. People awareness is important. Uh, we should disseminate our thinking among the general population so that patient may present to the appropriate place for early diagnosis. And simultaneously, the preventive measure is to be taken. So there are a lot of plans to be needed, not only by the individual hospital or individual association, but also by the government as a whole.
Exactly, sir. Thank you so much. Thanks for your all the presentation and information. Uh, So now I'd like to go to Dr. Professor Melissa Theo. Uh, as per our today's topic, with your vast experience, if you kindly forecast on the advanced treatment options on the surgical oncology and the perspective of surgical oncology in the curing cancer or treating cancer, please, Dr. Theo.
Thank you very much for introducing me and for allowing me to share today. I'm going to try and share my screen right now. So please let me know if you can't see it clearly. Um, I do have quite a lot of slides. I will try to go through this. I understand that this is a mixed audience with a lot of the people from the public, but also some doctors. Can you all see the slides?
Yes, yes, we can see.
Great, fantastic. Please stop me at any point. If not, I will continue with my lecture and I'll be happy to entertain questions at the end of the talk. So you've kindly introduced me. I just want to mention a few things. I currently run my own practice, but before I came out to private practice, I was the head of surgical oncology at the National Cancer Center. There aren't that many surgical oncologists in the country. Many of the surgeons are general surgeons, and while they do a very good technical job, it was very important for the two of us or three of us who did surgical oncology to go and do this discipline, because we feel that, I guess, the discipline of surgical oncology means a thorough understanding of cancer and the biology of cancer. One of the things that I will talk about later on today is cytoreductive surgery and HIPAC. For the doctors who are in the audience, this is particularly useful to treat patients with peritoneal cancers, and we will talk a little bit more about that. As you heard, I was trained in Singapore, but I did go away quite a lot. I was in the States for a while, and then I was in Toronto for 2 years. I was interested in not just treating and doing surgery for cancer, but because I was very interested in curing cancer, it was also important for me to do a Master of Public Health at Johns Hopkins. My clinical interests include all gastrointestinal cancers, so stomach, small bowel, colon, as well as pancreas. I do a lot of colorectal cancers, pelvic cancers, peritoneal cancers that come also from the gynecological cancers. And I have a subspecialty interest in sarcomas and melanoma. I don't want to go too much into this. You heard about my fellowships and subsequently my path to becoming the head of surgical oncology. This is my current practice at Farrer Park. I hope that some of you will get the opportunity to visit it in the near future. I know COVID has made it very difficult for travel, but there's plenty of space. And if you are here, I'll be very happy to host you. So surgical oncology is not just abdominal surgery, obviously. When I headed surgical oncology, this was some years ago, I had within my group breast surgeons, abdominal surgeons, liver surgeons, head and neck surgeons, and thoracic surgeons. What is a surgical oncologist? People think that it's a general surgeon, but it's more than that. I would say it is a surgeon who specializes in cancer. This is important because I think we want to talk about the understanding of biology and the natural history of disease. Excuse me, I don't know why. Okay, but it is important for a surgical oncologist to work in a multidisciplinary team, and we work very closely with medical and radiation oncologists. We also work very closely with pathologists and geneticists, and these are all important people in the management of cancer. Very often I hear of a patient who tells me that when they went to a medical oncologist, the medical oncologist will tell them, start chemo today. If they see a radiation oncologist, the radiation oncologist will say, start radiation tomorrow. And if they see a surgeon, the surgeon will say, you need emergency surgery. Now, that is very confusing for the patient. And as a surgical oncologist, it is important that we plan out the treatment for the patient together with our medical colleagues. So what I do locally advanced colorectal cancer in this particular patient. I hope this is not too gory for the public, but this is a patient that had cancer coming out of an abdominal wound. Another general surgeon did the original surgery, but unfortunately the margins were not clear. The tumor recurred very quickly and it grew out through the wound. As you can see here, I have removed the tumor And the area of removal is such that we don't even go near the cancer. The entire area that is involved is taken out with a nice clear margin all around. There, it leaves a big hole, but a surgical oncologist should also have the expertise to understand how to reconstruct this. This is another patient with advanced rectal cancer. You can see that the tumor has grown out from the bottom end. And in addition to that, the tumor has also involved the bladder in this particular situation. Here, the entire anus and the rectum and all that has been removed, and I had to do a reconstruction. I will talk a little bit more about that. Reconstruction is important because you want to give the patient a good quality of life after that. Other tumors that I do are retroperitoneal sarcomas. Retroperitoneal sarcomas, the doctors in the room will understand this. They look very big and very scary, and very often we have to remove many organs. The big and scary ones look like this. We take out things like colon, kidney, gallbladder, small intestine. But sometimes if a small tumors, like the one that is situated in this big blood vessel, the inferior vena cava, this one is the one that was much harder than a big tumor like this, because the way it was situated was that it was lying within the biggest blood vessel going back to the heart. We call that the IVC, and a resection of this tumor, in fact, was a lot more complicated than a resection of this tumor. I will finish off at the end of the day about cytoreductive surgery, because we find that a lot of patients with colorectal, ovarian cancers, stomach cancers have peritoneal disease, and I want to talk a little bit about this technique. So many people think that, I do all these big cancer surgeries and therefore this is the way a surgeon should be. I would say that's not necessarily true. I think these are the attributes of an ideal surgeon: a very sharp mind, a very sharp eye, a strong heart, and I like to think the delicate hands of a woman, but I probably will offend many of the surgeons here. So I will leave you to judge for that. But I think most important is the fact that a cancer surgeon needs to be a thinking surgeon, because there are many things that can be done, but we always think first and then act later on. Now, cancer is such an important topic to me because in 2020 alone, worldwide, we had almost 20 million new cancer cases and 10 million cancer deaths. Now, that is a significant number of people to die from cancer. The commonest cancer in the world are breast cancer, lung cancer, colorectal cancer, and of course, many other cancers fall into the subsequent positions. But we also know that if we think that the numbers of cancer are high now, wait till another 10 years later when they will continue to double. So this is a pictorial representation of the kind of cancers that represent what we see in the world. But important to us, I want to go, is, in the local population, we see also that breast cancers, colorectal cancers, and lung cancers, just like in the rest of the world, these are the commonest cancers. So we start to see a trend in all the countries, developing or developed countries. When I did, and I was in charge of building the new cancer centers in Singapore, we did a study and we saw that almost 20% of our population with chronic disease have cancer, and that a third of our people die from cancer. Our worry was that in the next 10 years, and we are in 2021 now, the cancer prevalence will increase by 3 times compared to 2008. And that, a lot of the cancer burden is in the public hospital. There are many cancer control strategies in Singapore. We do cancer prevention, cancer screening, and I will talk a little bit about that. The National Cancer Center allows us to consolidate our efforts, but it is important to train oncologists and healthcare workers. And over the years, I've had the privilege of meeting many young doctors and surgeons who have come to Singapore to join me and to spend a period of time training so that they can return back to their country and contribute to the care of patients in their country with cancer. It is important for us to also remember that cancer patients don't just require surgery, chemotherapy, and radiation, but that we pay attention to the rehabilitation of these patients and palliative care so that they can have a good quality of life that is pain-free. I think that when we collect the data and do the research, we will learn a lot more about our own patients. So, but what is cancer? For the lay public, we want to know, because we hear this term, and every time I see a patient in a local population, they will ask me, do I have the big C? So cancer is actually a group of diseases. It can affect any part of the body. We call them malignant in the medical term, but essentially it is abnormal cells that grow beyond what the usual cells do. They invade into nearby parts of the body, and they can also spread to other organs. And when they do spread, we call it metastasis. And obviously, patients that have metastasis have stage 4 cancer, and metastases are often the main cause of death from cancer. Why do people have cancer? Well, normal cells can change into tumor cells, often through a multi-stage process. So you see here, colon, and this is a polyp, and the polyp slowly grows from a small polyp to a bigger polyp, and as it grows, the cells within the polyp changes, and eventually it becomes cancer. And when it becomes cancer, it can invade deep into the cells of the colon and spread to other areas. Obviously, genes in our body can predispose us, and that's the reason why we always ask for a family history when we ask about cancer. What causes cancer? Cancer is basically an interaction between your genes and other external factors. Obviously, there are carcinogens in the environment. When we stay out in the sun for a long time, you get ultraviolet rays. Ultraviolet rays can predispose to skin cancer. Radiation can also do that. But sometimes we consume carcinogens, chemical carcinogens, when we take part in smoking, when we take a lot of processed foods, when we take a lot of chemicals in our food, we are consuming chemical carcinogens. And obviously, we also have biological carcinogens, which are infections from certain type of viruses. So NPC is associated with EBV viruses, and obviously cervical cancer is associated with HPV viruses. So these are important. As we grow older, the chance of cancer becomes higher, and that's because an older body has less capacity to repair the cells, and this is also an important factor to note. I mentioned earlier, many patients ask me, how can I decrease my chance of getting cancer? And I will say, if you know that the risk of cancer is increased by tobacco utilization, alcohol utilization, unhealthy diet, physical inactivity, and pollution, then you need to avoid these things, right? Chronic infections, unfortunately, are rampant in low and middle income countries, and we have to do our part to eradicate. And that may sometimes mean vaccinating against hepatitis B, hepatitis C, and of course now cervical cancer vaccination is important as well. Now, I want to highlight one or two cancers that I do very commonly. Colorectal cancer, which we see is such a common cancer in the world, and in Singapore, this is the commonest cancer. It is also a very deadly cancer, even though it actually can be detected very early. Colorectal cancer means a cancer that is situated any part along the large intestine, and you have the ascending colon, transverse colon, descending colon, sigmoid colon, and the rectum. And of course, rectal cancers have a worse prognosis. Now, many famous people have cancer, and I think probably most people know, I'm sure you have watched Black Panther. Black Panther, the actor there, Chadwick Boseman, was unfortunately a very, very young guy. He died at the age of 34, and it's terrible because, we probably, he died at the age of 43, and it's terrible because we probably could have saved him if he had gone for colorectal cancer screening. So we mentioned that colorectal cancer starts from a polyp, and it takes years. So in this diagram here, you see again a polyp that starts really small and growing through the years. And if you imagine that a polyp takes about 10 years to become a cancer, we have that opportunity to remove that polyp in that 10 years. And if we did remove that polyp, then this patient is not going to have colorectal cancer. This is a colonoscopy picture that shows a tiny polyp, and this is really easy to remove. Even this is easy to remove, but when it becomes a giant polyp, it gets harder and harder. And obviously, by the time it becomes a cancer, we cannot just remove the polyp. We often have to do a resection of that segment of the colon or the rectum, and that means surgery under general anesthesia. Other risk factors that age, gender, family history of colorectal cancer, obviously a personal history of colonic polyps, and there are many other hereditary conditions. Plus, remember I mentioned just now the lifestyle factors, alcohol, smoking, but also if you take a very high-fat diet, if you do not look after yourself, obesity also contributes to these risk factors. Other things, that I mentioned just now, diet, a lot of meat, very little vegetables, no exercise, smoking, obesity. So patients, please look out for this. If you have blood in the stools, otherwise known as per-rectal bleeding, if you have a change in your bowel habits, which means to say, if you normally have regular stools, but suddenly you have a lot of diarrhea and it continues, or you normally have diarrhea, but now you have constipation, or you go to the toilet and you feel something is not right, it's not emptying completely, or the size of your stool changes. These are worrisome symptoms that you should highlight to your doctor. Certainly, when a patient has a loss of appetite or loss of weight, these are things that I am concerned about. Now, some patients have abdominal pain, bloating, and these are very generic symptoms. So it is difficult, but do not dismiss your symptoms because we don't know if there is something serious underlying your common symptoms. Some patients have no symptoms at all, and that's where screening comes along. So if you're worried at all, please check with your doctor, who should take a complete medical history, do a physical examination, the blood test, and sometimes, if necessary, they may do scans or x-rays, and definitely, if warranted, a colonoscopy, which allows us to see what's going on and to do the necessary biopsy. Now, the reason why I keep on talking about going for screening is because we know that the survival of colon cancer is very dependent on the stage. If you have stage 1 or stage 2 colon cancer, the 5-year survival is 90%. If you have stage 4 colorectal cancer, your survival is less than 20%. Now, of course, if we really needed to have colorectal cancer, who doesn't want to be diagnosed in the stage 1, stage 2 phase of colorectal cancer? Everybody, if you needed to have a colorectal cancer, right? And better yet, if you didn't need to have a colorectal cancer. So my point is, always be aware of what your body is experiencing and highlight it to the doctor if you think something may not be right. If you're of the correct age, even go for screening when you have no symptoms so that you can pick it up at the pre-cancerous phase. If you have early stage cancer, surgery is all you need. If you have advanced stage cancer, you may require chemo, radiation therapy, and if it has spread to everywhere else, sometimes cure becomes difficult. Prevention is always better than cure, and many different countries will say the recommended age for screening is 50. If I'm not wrong, in the States and in Singapore, it has changed to 45. This article was published in 2007, but of late, we have now switched to 45 years of age, okay? So, if you look at people who have been segregated into two groups, the people who came for screening lived for much longer. The survival probability is 80%. If they waited till they had symptoms, the survival probability is 50%. So definitely you want to belong to the upper group if you were to have colorectal cancer. There are many other ways of diagnosing it. Of course, you can do a stool test, a barium enema, a CT scan. Obviously, if any of this show abnormalities, a colonoscopy is still going to be required for the biopsy before surgery. So colonoscopy allows us to see what's going on. It also allows us to remove polyps, and it allows us to do a biopsy to confirm cancer. But I want to switch tack now and talk about stomach cancer. Now, stomach cancer is not as common as colorectal cancer. It is, however, still very deadly, and it is such an easy cancer to pick up because we can just do a scope. Now, these are the risk factors for stomach cancer. H. pylori infection, which is a very common infection in many parts of the world. Pernicious anemia, which is not that common. But again, the lifestyle factors that I keep on talking about, obesity, diet, smoking, alcohol, family history, these are such important things that we can change right now. So if I haven't said anything of importance today, please relook at your life and think about how you can get to a healthier phase of life. In the early stages, stomach cancer usually has no symptoms, but in the late stage, these are the symptoms that one might have: bloatedness, abdominal pain, loss of appetite, nausea, vomiting. Sometimes people will bleed, and that will result in the passage of black stools. And of course, we can have symptoms of anemia, breathlessness, chest pain, tiredness. These are things that we have to watch out for. Again, stomach cancers can be diagnosed just on a scope. The scope is often done under sedation. It goes through the mouth, down the food pipe, otherwise known as the esophagus, and into the stomach, where we can see these things, and we will do a biopsy of the edge of the ulcer, and that will give us an answer. Again, stomach cancer, early stage, good prognosis, or at least better prognosis. Late stage, terrible prognosis. In fact, if you look at stomach cancers, the survival stage for stage comparing to colorectal cancer is already worse. Now, I was asked to talk a little bit about what I do, what other surgeries I do. Now, this is going to be a little bit technical. I apologize to the public. This part is a little bit for the doctors. Now, patients sometimes come to me with very bad rectal cancers or gynecological cancers like advanced or recurrent cervical cancers. I sometimes have to consider a pelvic exenteration. A pelvic exenteration means removal of many things in the pelvis. The things that are in the pelvis include the bladder, the uterus, of course, the gynecological organs like the fallopian tubes, ovaries, vagina, and then of course the rectum, the sacrum, and there are many, many important vessels and nerves. When you have a big hole, remember I showed you just now, that needs to be reconstructed. Now, many of these patients have these cancers that I mentioned, rectal, anal cancers, gynecological cancers, even prostate cancers sometimes fall into the category. This is a woman with a tumor that went out and it was involving the anus. And we looked at the scan and you can see the tumor here is going through from the anus all the way to the skin. It came through the skin, which is why we saw it. This is another view of the scan. Again, you see the tumor is really, she can't even sit because this tumor is like a big ball at the bottom end, right? Now, we always do the scans. The scans show us things like how big or how deep is the tumor. Can the anus be saved? Because many people would like to save the anus. How likely are we to be able to get clear margins all around? Because I hate leaving cancer behind. And what are the other organs that are involved by the cancer that I have to tell the patient I need to take out? So this is an example of a patient that saw me, Indonesian patient that I saw more than 10 years ago. He had seen about 3 different doctors and everybody said not resectable. He came to Singapore, he saw 2 other doctors. Again, they said not resectable. He went through chemo and radiation, but the tumor kept growing and he was only 27 years old who had just gotten engaged to his fiancée. He was told that he had 6 more months and that he should go on his honeymoon. And by the time he came to see me, he was peeing out rice. So every time he ate, he peed out rice and he was always having a urinary tract infection. Now, why would he pee out rice? And the reason why he was peeing out rice was because there was a communication between his rectal cancer, which has now grown so big, it eroded through into the bladder, and such that anything that he ate went all the way down, was not digested well, went down to his intestine, and then it went into the bladder, and that's why he peed out the rice. Of course, if you look at a scan, you will see, for the doctors in the group, you will see air in the bladder. We never have air in the bladder unless the patient has a fistula. Okay? Same thing here, you see the scan, there is air in the bladder, and the bladder is very thick because the bladder is very inflamed and infected. An MRI showed that he had invasion of the dome of the bladder with fistula formation. He also had tumor coming through the anterior abdominal wall. And I removed the tumor. This is the abdominal wall. This is the subcutaneous tissue, the muscle, the bladder, the rectum. I did not cut into the tumor at all. And this is the important thing if you want to be a surgical oncologist. You cut around the tumor. As I tell my residents, it is easy to do cancer surgery. You draw a circle around the cancer and you never go inside the circle. You only stay outside the circle to ensure that you get clear margins, and that gives the patient the best chance of survival. You see, when we open up the bladder, there is tumor inside the bladder. Of course, after that, there is an empty pelvis. We have to reconstruct. How do you reconstruct in a patient that has the entire bladder taken out? Well, if you have part of the bladder taken out, you can close the bladder up and stitch it up. If you have a majority of the bladder taken out, you can try to use bowel to augment the bladder. But if you're taking out the whole bladder, then you need to reconstruct. And very often I like to use an ileal conduit, okay? But I didn't show the ileal conduit. An ileal conduit is basically using a segment of the terminal ileum that we harvest. We put the 2 ureters into the ileum, and then that comes out as a separate stoma. And in fact, I am doing this surgery in about 2 weeks' time for another patient. Now, when there is a big hole in the pelvis after we've taken out that big tumor near the anus, we have to fill up the hole. And one of the flaps that I like to use is a muscle and skin flap that I take from the patient's body. So I cut around here, and then this muscle is dropped into the pelvis, and it is brought out through the bottom end to fill up the hole. So I'll give you an example. This is a woman that I saw when I was at the National Cancer Center, and she had a tumor that was going into the vagina as well as the muscle around there from a recurrent cervix. Now, you see the tumor is very small, but it is involving the small bowel loop, and it is involving the entire vaginal canal, and the tumor came out at the orifice of the vagina. I did not cut into the tumor. Remember, draw a circle around the cancer and never get into the circle. Cut around that circle and give the patient clear margins. I used the muscle flap from the patient. I dropped it into the pelvis and I stitched it up such that she had the bottom end of her vagina reconstructed. And then, of course, this was like an APR. This is the umbilicus that looks a little bit like the anus, but obviously she needed to have a permanent stoma. This is another example. He was a young Muslim man who really did not want to have his anus removed. He had a tumor that continued to grow. Unfortunately, it caused him so many problems. When he saw me, he told me he has not sat down for more than 6 months. He could not sit down to eat his dinner with his family. He could not sit down to do anything. He could not sit down to pray. He was always standing up, and he was so tired. We had to take out the whole tumor, and eventually he had a big, huge hole at the bottom. So I didn't go into the circle. I drew a circle around the cancer, and I stayed outside because I knew that I could reconstruct this by using the flap that I was talking about. And that flap was from the front of his tummy, and I brought it out to the bottom, and then I closed the wound like this. So this is his muscle flap. He didn't have a hole. The first thing he did after the surgery was to sit out in a chair with a big smile on his face. So I think this is important because we reconstruct so that the patient can have the quality of life back. I want to finish off the talk today because I promised to talk a little bit about peritoneal cancers. Now, what is the peritoneum for the public as well as for the doctors? The peritoneum is a lining inside the tummy, all right, that is, like I always mention, if you have an expensive handbag, that expensive handbag will have a lining inside. This lining is known as the peritoneum, and it surrounds all the other structures in the handbag, all the other things in the abdominal cavity, right? So peritoneal cancers come from many things. Very often, they actually don't come from the peritoneum themselves. They come because they are metastasis or a spread from other cancers, and the cancers include colorectal cancers, ovarian cancers, gastric cancers, or stomach cancers. All of these cancers can spread to the peritoneum. And when they spread to the peritoneum, many times they are told that this is stage 4 and not curable. Well, I beg to differ. Peritoneal cancers, we know, are very, very advanced, and they are often told that they have 6 months left to live. Many, many times, because the disease is inside the tummy, it may involve the intestine, and when it involves the intestine, the patient can have intestinal obstruction. So we ask ourselves, should we cut out all the tumors in the tummy, and will that help to relieve their blockage and improve their function? Well, what happens if we don't treat the peritoneal cancers? You know, the peritoneal cancers often are diagnosed late because on the CT scan, they may not always be seen very clearly. When we treat the patients with peritoneal cancers with chemo, they don't respond unlike those that have tumors in the liver and in the lungs. And again, many of them, even though they say we want to give them chemo, they can't even get chemo because they have intestinal blockage and they come to the hospital requiring emergency treatment. Why are they diagnosed late? If you look at it, and this is when I open up the belly of a patient, these tumors are many, but they are so flat. They are so flat. They are almost like a tiny little piece of pancake. And when you look at the CT scan, in this particular patient, none of this disease was actually seen on the CT scan. So it's hard to pick up because even if there are many, it's very flat. Look at these cancers. Look at the nodules here. There are so many that I can see here, 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 here. But do you think that this can be picked up on the CT scan? No, because even a PET scan can only pick up things that are 5 millimeters and bigger, and these are way smaller than that. I talk about how they are not responsive to chemo, and this is a study that showed in a person with peritoneal metastasis and another one without, when they compared the two groups, the ones with peritoneal metastasis, even if you gave them the same chemotherapy, they always did worse, always. And the last reason is that they don't even receive treatment because they are always in the hospital for emergency problems. This is a CT scan of a patient with intestinal blockage. You can see the intestines are blown up like balloons filled with water inside them. And when we do an operation, this is what you see. After the blockage, the intestines are collapsed. They are very small, but before the blockage, the intestine is blown up like a balloon. I apologize again. I know that it will be dinner time for many of you. I hope you don't get sick. In the National Cancer Center, many of the patients with peritoneal disease are told by the medical oncologist that they would give them chemo. The truth of the matter is that less than 1/3 actually receive chemo because the majority come in with many, many problems and they never get the chemotherapy. We need to be better in treating our patients, and that's where the cytoreductive surgery, or CRS and HIPEC, comes about. This is the radical resection of all the tumor in the tummy. We remove everything that is macroscopic that we can see. And the rationale is that if the tumor has not spread via the bloodstream, via hematogenous spread to any other part of the body, and it is really just that primary tumor rupturing and causing tumors everywhere in the tummy, maybe if we cleared it out, again, remember, draw a circle around the cancer and cut outside the circle. If we clear out all the cancer and then we gave chemotherapy into the belly, could we change survival for these patients and cure some of them? This is a patient with a huge omental mass. Because of peritoneal disease, the cancer was really involving a lot of occupying all this space in the tummy. We took this out along with all the other organs that were involved, gave him chemotherapy. He is alive 10 years from this diagnosis. Now, people say, how are you going to treat this? You know what? It's not that difficult. If you have the patience, you can remove all of these tumors, right? Now, after we remove all of these tumors, we then say, do you think that there are still cancer cells in the belly? Of course, the cancer cells are tiny. So for the cancer cells that our eyes cannot see, after we have removed the big chunks of tumor, we wash the belly with very concentrated chemotherapy. Now, this is very, very attractive because the patients do not have the side effect of chemotherapy that is given through the veins. You know, it doesn't cause them to have their hair fall out. They don't get the nausea and vomiting. We wash it with chemotherapy at the area where we know there was a lot of cancer cells. And we do it at the time of surgery during general anesthesia. And after that is washed for about 1 hour. We wash it again with water before we close up. This is how I do a peritonectomy. I position the patient like that. It allows me to reach every part of the tummy. I remove the whole sheet of the lining or the peritoneum that contains all the disease, leaving clean muscle underneath. For the surgeons in the group, we often score how much disease the patient has using a score known as PCI. You can email me if you have other questions on PCI. And we talk about whether we cleared all the disease, in which case it is a CC0, or we only did a CC1 because there was too much small bowel involved. We should never do the surgery if we're going to be leaving tumors that are the size of CC2 or CC3 behind. This is a patient from Jamaica who came to see me. And you can see huge belly with tumor. After surgery, this is what it looked like. I like to wash it because I like to get rid of all these cancer cells. This is why we give HIPEC. You can give very, very high doses of chemo and it will allow us to kill the cancer cells. We use a machine to do that. The machine looks like this. I know it looks scary, but you know, when the patient wakes up, all he has are a few drains. He is not connected to a machine, obviously, at the end of the surgery. This is all disconnected. So sometimes we come across evidence that show that, you know, chemotherapy in the belly will improve the care. And in this particular newspaper cutting, it showed that there was a study that says that CRS and HIPEC will improve ovarian cancer survival, heated chemo bath. After that paper came out, you know, many patients came to look for me to say, I want the heated chemo bath. Newspapers are even more influential than medical journals, as you can see. It reaches a much bigger audience. This was the original paper by Vendrell for the surgeons who want to refer to it. It's a very important paper. But importantly, I also did some experiments in the lab just to summarize, these are mice with cancer. If I didn't treat them, they continue to have cancer growing. And after I sacrifice them, after 6 weeks, you see so much tumor. These are mice that I gave chemo into the belly. I had to sacrifice them even though they were very well. You see a lot less cancer. In fact, the ones that received chemotherapy, they went on to live. And if I didn't sacrifice them, they would have drained all my resources because they would have required me to feed them indefinitely. The mice that didn't receive treatment died within 2 months. So I have many brochures. Some of you may want to have more information. Please feel free to email me. One of the other things that I have also started doing at Farrer Park Hospital is PIPAC. PIPAC is giving chemotherapy. Not everybody with peritoneal disease can have their tumors cut out. Some patients come to us very, very advanced, and if we cannot do CRS and HIPAC because all the disease cannot be cut out, there is still hope. I can give them chemotherapy into the belly in a pressurized fashion, and a couple of cycles of this may induce a great response that allows us to eventually treat the patient with CRS and HIPAC. I work with a team of superstars. I hope that you can come to Singapore to meet all my nurses and the allied health that work with me. Please feel free to contact me. These are my contact details. And I would like to end the show now. So,
Thank you so much, Dr. Melissa. It's a huge thing, huge information is already there. So yeah, I mean, there are lots of hope with lots of good options, advanced treatment management in Singapore. Uh, During your session, I had a question that the surgery is usually we do considering to have a relief to relieve our uncomfortableness, okay, to discomfort. So the surgery is looking too much scary for us. So how you ensure the comfortable life after this surgery, and how
so that's a very
quickly
good question, Fazana. In fact, many times people ask me, "Oh, you do such surgeries, and yes, you cure many people, or you give them long survival. But what's the point of survival if they have to go home in a wheelchair and they cannot?" And I will tell you, my patients are often discharged within 7 to 10 days, even after the surgery, and they walk out of the hospital, right? And they are eating, bathing, feeding themselves on their own. And when we did a study on quality of life, most people return to their original quality of life within 4 to 6 weeks, and everybody returned to their original quality of life within 3 months. So if I were to give a question to a patient with cancer, I say, let me tell you that I can give you extended survival and you will walk home after 7 to 10 days, plus return to your usual quality of life or better within 4 to 6 weeks. I am sure that the patient will say, please do the surgery.
Yeah, absolutely.
Yes?
And another query, usually patients wants to know from the doctors with
Yes.
colorectal cancer that
Yes.
what should be the diet for them or the nutrition, because there is a whole lot of confusion about the diet and the food intake for the colorectal cancer patients. So if you kindly inform about this.
So I think diet is very important, but I think diet is particularly important in the cancer prevention phase of things. So I always say high fiber diet is much better than a high fat diet. Vegetables, 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 meat less, right? So I think that I'm not saying that everybody needs to become vegetarian or vegan, but I think that these are important things to take note of. That we should mostly be focused on vegetables and have just a little bit of meat, and in that way, it will reduce our chance of having colorectal cancer.
Okay.
Now, I see that there are quite a lot of questions in
Yes.
the comments. Should I address some of them?
First of all, Professor Anwar sir, would you like to share any of your information or anything you want to add with Professor Melissa View?
First of all, a lot of thanks to Professor Melissa. It's a great talk.
Thank you
She
very
has
much.
covered she has covered a lot of things, starting from the stomach, colon, and up to the CRS hyphen. Actually, uh, in our country, we are not yet established any center or any place in CRS hyphen. And
Yes,
this is why peritoneal disease malignancies are still in a uncomfortable stage, and we are
yes,
doing surgery, but postoperatively peritoneal, intraperitoneal chemotherapy we cannot arrange over here. There are
yes,
few centers even in India they are doing also. Uh, that is why
yes,
I'm always talking that Singapore is in between the east and western world. So you
yes,
can understood about the patient's situation of our country, but
yes,
you have that much expertise and equipped enough to do anything for the patient's safety or patient's comfortable. So main important thing is the quality of life of the individual patient.
I
Even
agree.
even if patient present to us in a very advanced stage, even though we go for whatever may be, it could be chemotherapy, it could be surgery in some stage, but it is for the sake of patient's comfort, and that is why that is an important issue is the quality of life. So long patients survive, we think that they should remain in a very comfortable life. That is the main theme in advanced stage of the disease patient's outcome. So you have very nicely showed important issue regarding the advanced stage disease, how you handle this. Even there is a not only the hyperexeris but also the exenteration. In some cases, we have faced this problem. Patients present with high- that is the important issue is that patient present with fistula, in between the bladder and colon, in between the urethra and the colon or rectum. So that is the different problem, and
Yes,
patient present in a very late stage. So there is
yes,
question of exenteration, and that is a very important issue, and it is a difficult task in our case too. And
yes,
even patient, in case of even a very in case of lower rectum cases where we give radiation and chemotherapy, then go for surgery, and
yes,
we use defunctioning ileostomy. In these cases, even patient not allowed to do this ileostomy. They do not like to advocate this. These are the technical problems over here. So there is
I understand.
needs a lot of counseling before doing surgery. Even we show these patients having this type of disease so they can
Yes,
understand that how they behave. So a lot of things come forward, and we should always optimistic regarding the patient management and counseling. Thank you.
Definitely, I think we need another session to discuss more about this because lots of queries are coming. But by this time, when I was talking with you, you focused on the palliative care and the rehabilitation of the patient, cancer patient. So, to discuss about this, actually today, Bangladesh Cancer Aid Trust is our associate partner who Ms. Fatima to Zohra, lead corporate affairs and communications of Banquet, joined us to inform you something, a very good news about Banquet and their activities recently they did. Just before of that, let me introduce you about the Bangladesh Cancer Aid Trust, which is a voluntary organization that helps underprivileged patients suffering from cancer and also encourages and creates awareness on cancer to connect present patients with the survivor to promote positive mindset regarding cancer. So I'd like to hear from Fatima Appa. So please. the dream project you want to announce, inform our patients, please.
Napa, and it's great to be with Professor Melissa Theo and Professor Dr. A.F.M. Anwar Hossain. I've been hearing both of you since the beginning, and it's been a very informative session. So thanks to both of you. So at Bangladesh Cancer Trust, what we are doing is we're a nonprofit, so trying to support the underserved cancer patients. So far, we have been trying to support the financial part of it, but then again, only supporting the patients with finance is not enough. What we have seen or how we feel is treatment is only one, is the majority portion of it, but then again there are other aspects as well. When we talk about holistic wellness, when it comes to the mental health of the patient, when it comes to what type of nutritious food that they should have, and also the type of physical fitness that they need when it comes to maybe working out, yoga, and things like that. So what now we are trying to do is we are trying to create a cancer care home for our patients, because majority of the patients that we cater, the underserved patients, they come from outside Dhaka city. They live in the rural areas, and when they come to Dhaka city for the treatment, majority of the time they do suffer with scarcity with accommodation, and when they go through their chemo or their radiotherapy, the immune system obviously drops. So we want to ensure that during those days they stay in a safe place where we will be able to support them with a complete care package. So that's how we started. Our project is under construction. The name is Alok Nibash. It's going to be a small residence which is going to cater 25 patients at a time. We're going to try to give them a small space where they can sort of feel and alive, and also feel that there is somebody beside them when they are suffering from their cancer. So that's what the cancer home is about.
This is very fascinating and good news for our patients. And IMIC always feels proud to be a partner of Banquet. And definitely there will be more programs with them to create more awareness for the Bangladeshi patients. So thank you, Fatima, for joining with us. Now we will take some questions from our audiences, and then we will finish our session. So, Dr. Theo, do you want to answer this question? Is it possible to be completely cured from the cancer with Whipple surgery if a patient is suffering from pancreatic cancer? Because it's a term very much common here. When you're suffering from pancreas cancer, Whipple surgery is the option, only option.
Yes.
So, your
So,
opinion.
so pancreatic cancer, obviously, as you know, is a very aggressive cancer, even more aggressive than stomach cancers or colon cancer. It has a completely different biology. And in fact, of people who have diagnosis of pancreatic cancer, maybe only about 25% of them will be able to undergo Whipple surgery with clear margins. Clear margins is always very important. And even if they are able to undergo Whipple's operation, 25% of them will be cured for life, and 75% of them will have recurrence. So the survival chance of patients with pancreatic cancer is a lot lower than with colorectal cancer or stomach cancer, but it is possible to be cured from pancreatic cancer with a Whipple surgery if the tumor is diagnosed early and the surgery is done well with clear margins. Yes. I see another question about how long a patient should wait after surgery for
There's a
further.
whole lot of confusion about this, how long a patient should wait after the surgery for the chemo. So,
So, in my opinion, patients who require chemo or radiation have advanced cancers. Advanced cancers usually means stage 3 or stage 4. The ideal situation is that the surgery is well done. And remember, just now I told you that even when I do a very big surgery, I most of the time the patient is discharged within 7 to 10 days. I try to get my patient back to chemotherapy again within a month of the surgery, and that means within about 3 weeks after discharge, they should be able to start. The fastest I've ever had anybody start the chemotherapy after a big operation is 1 week, and of course, the longest may be longer if they have had complicated recovery process. But the fastest is 1 week, and the average should be less than a month.
Okay. So, thank you, Professor Theo. I'd like to ask Dr. Professor Anwar sir. This question is, my husband diagnosed with fourth stage colon cancer, and also he has some lymph nodes in the liver. Is there any role of colon surgery?
Yes, there is no lymph node in the liver, but there could be liver metastasis. It could be. Uh, so, though it is a stage 4 disease, even then, surgical intervention can be done in those cases where there is patient didn't have any previous surgery. So, there could be the possibility of obstruction. If there is obstructive cell, then go for surgery. If there could be the possibility of second look surgery following chemotherapy or even radiotherapy. But in general, if it is a very disseminated disease in the liver, lungs, and the peritoneal, then it is only for palliative measures to reduce the bulk of the tumor, to reduce the uh, morbid condition, or in other words, to uh, give comfort to the patient. Sometimes it is needed to do only ileostomy in a stage 4 disease. Nothing can be done. So this the situation uh, demands depending upon the different issues. So a lot of things come forward, and all these things will be materialized, and then make it plan what will be the appropriate measures needed for that individual patient. I think Professor Melissa can add.
Yes,
We yes.
I agree. I mean, I agree. There aren't any lymph nodes in the liver, and I worry about liver metastasis. It is, of course, as what Prof. Hossein has said, it is possible, but we need to know, obviously, the extent of the liver metastasis or the liver spread. It is good to know also the duration between the time of the uh, primary tumor and the recurrence. But in general, the outcomes for liver resection for a colon that tumor that has spread to the liver are quite good if again we can ensure that we have cleared all the disease. Obviously, a person with one or two liver tumors, uh, completely different diagnosis or prognosis from somebody who has many, many, many liver tumors. So if the whole liver is filled with tumor, then surgery is probably not the way to go. But if there are just a few and the surgeon is confident of being able to remove all of it clear, then yes, it is possible.
Okay. So the last question, my mother 6 months back had a colon surgery, and after that there is a hernia growth which needs to be operated. Still, she's suffering from constipation. What's your advice, Dr. Theo?
So sometimes when you say hernia, I guess hernia or growth, they're a little bit different. But I presume if you say hernia, then yes, I guess a hernia should be operated on unless it is a very wide neck hernia, because hernia sometimes causes intestines to be blocked up, and the patient can present in a very emergency fashion. But the hernia and the constipation may or may not be related. We need to figure out why the patient has constipation now. Is this constipation related to the surgery? Usually it is, if it happened right after the cancer surgery, then we worry that maybe the joining where they put the two ends of the bowel together, was there a problem? The joining was too tight. That's why the patient has constipation. Or was the patient not constipated after the surgery, and this constipation is recent over the past few weeks, in which case we worry, is there a recurrence in another part of the colon or a recurrence at the area of the joining? So, two separate things. One is about the hernia, and the other is about the constipation. Need to figure out what's going on with the constipation before we jump in to do another operation for the hernia.
Thank you. So, thank you, Dr. Professor Melissa Theo and Dr. Anam Hussain sir, for your valuable time. And definitely, we'll look forward for another session with you, because I think this is not actually enough people have also added queries even. So thanks everyone for watching us. From the session, a few advices we can inform you that the vaccination is really important. Early detection is also really important to have a surgical procedure before it gets in a bad condition, and always listen to your body if something is unusual. So all these things will help us to prevent cancer and spread awareness among the society, so that people continuously tries to do screening before having bad news from the doctors. So thank you everyone. Thanks for watching. Definitely we will do more webinars like this. Uh, Stay healthy and happy. Thank you.
Thank you. Thank you, everybody.
Thank you. Bye bye.